Hello and greetings everyone. Welcome to the 39th session of the online Optom learning series. Let me go and introduce to you our speaker for today. Today we have Mrs. Prema Chande. She's a well-known optometrist. She's graduated from the Elite School of Optometry in 1992 and presently she's a PhD scholar at the Chitkara University in Chandigarh. She is the principal of the Lotus College of Optometry since the inception from the year 2000, and she is a consultant optometrist at Roshni Eye Care, which is a private practice. She has been a principal investigator for several community eye health projects. To name a few, Sight for Kids, Mumbai Eye Care Campaign, and Mumbai Childhood Blindness Prevention Program. She is also a board member of the ASCO, which is Associations of Schools and Colleges of Optometry India, and also Optometry Council of India. She is into advocacy of optometry since a very long time, and she represents India on the World Council of Optometry's Public Health Committee and Task Force member of the proposed Allied Healthcare Council of India. And this is by the Ministry of Family Health and Welfare. She is on board for the Asia Pacific region as an board member for quite some time, and she is also a recipient of the award of the International Educator for the year 2016 for the Asia Pacific region for IACL, and recipient of the Excellence in Ophthalmology and Vision Award 2017 by Novartis. She is also awarded by the Rotary Club of Bombay Seacode in 2018 for her work in community eye health. She is also a recipient of the Best Optometrist of the Year award by Shankar Netralaya's Elite School of Optometry, Chennai in 2018. And today she is going to talk to us to a very important topic, which is the role of optometrists in prevention of blindness as practitioners, and are we doing enough? Over to you, ma'am.
Thank you, Fakhruddin. Good evening, all of you. And I'm quite happy to see a number because I was a little worried when we said prevention of blindness, whether we will really have optometrists who would be interested in listening. Because this is one area I always feel we are not doing enough. So I'm just going to share with you some facts and figures, and of course, a little bit of my own personal experience or my personal cases where I think, that when you all have such similar cases in your practice, whether you can think of prevention of blindness, right? Okay. So before I begin, I would like to thank Fakhruddin for giving me this opportunity. I think I must congratulate him on this online Optom learning initiative. It's a very good initiative, and the fact that this is the 39th session, that shows it must be pretty popular because during lockdown we know a lot of webinars are available, and if this one has been going strong for almost such a long time, it must be a very popular one. So congratulations, and thank you for giving me an opportunity on this. So going ahead, I think all of you must be familiar with some of these figures, right? This is the 2005 statistics of the World Health Organization, which said that there were 285 million people who are visually impaired worldwide, 39 million who are blind, and 246 million who have low vision. Now, this is the 2005 statistics. I'm not going to run you through all those points over there, but yes, 90% of these visually impaired people live in developing countries, right? And a lot of Asia is Southeast Asia, especially, is a large part of this developing world. If you look at the same reported data age-wise, it showed that most of these people who are visually impaired, most of the population is in this age group of 50 years and older. Out of that population group, 186 million are in this age group of 50 years or older. And if you look at this overall number of visually impaired, it is close to about 600 million. Now just see where that data has grown in the past 15 years. This is the most recent WHO World Vision Report, which was launched during the World Sight Day last year. So what does it say? Of course, the definition of vision impairment has been modified to include refractive errors. So today the number has grown to 2.2 billion people. And this includes uncorrected refractive errors, which is a large chunk of it, 123 million, followed by cataract, followed by glaucoma, corneal diseases, diabetic retinopathy, and so on. Even if you remove the uncorrected refractive errors and presbyopia numbers, this alone amounts to about 1 billion. So I understand as optometrists, we all do our bit for refractive errors, right? So I'm not going to talk to you about myopia control, school screening programs. I'm sure you heard of a lot of all of that. Let's focus on this 1 billion today. Are we doing enough? Besides this data, which shows that there are 1 billion people, there is another thing which is very, very disturbing. It is the overall changing demographics, especially if you look at India and Southeast Asia. We are today celebrating that we had, at one point, a few years ago, we were celebrating that we had a large number of young people in the world. We said we had the youngest population, which means economically growing population, and so on. Today, all the ophthalmic companies are wooing our presbyopic population because we have a large presbyopic population. So what are all the options available, from various progressive designs and spectacle lenses, treatment, multifocal IOLs for the younger generation. We are talking of multifocal contact lenses for this population today. But what's going to happen tomorrow? We are also going to have a large number of people who are above the age of 60. You can see here, almost by 2050, we are going to expect that such a large population is going to go towards the age of 60 years and above. So going back to that aging data details, we know that a large chunk of our population is also at the risk of developing vision impairment. Okay, so let's look at those numbers. As I said, we are going to focus on that 1 billion today. Cataract is one thing which is extremely well managed because it was the leading cause for blindness for over 50 years. And now the numbers are coming down. Still, of course, it remains the leading cause. But I think there is adequate work being done for cataract. Optometrists, primary care practitioners, even opticians in countries, primary healthcare workers are also trained to detect cataracts. So is the awareness for cataract among the population itself. Today, they are not surprised if they are diagnosed with a cataract. And in fact, they even ask, what kind of an intraocular lens are you going to implant in the eye? But unfortunately, that awareness level does not translate for conditions like glaucoma and diabetic retinopathy. Let's look at us as optometrists. We are primary eye care practitioners, and optometrists play an important role in early detection, prevention, and awareness generation. Let me tell you a story on awareness generation. When I was early in my days of community eye care, I was having a discussion with a very senior community, well-known community ophthalmologist, Dr. Uday Gajiwala. I don't know if you know him. He's from Gujarat. So I remember telling him this during my Mumbai Eye Care campaign meetings. One of it, I told him very disappointedly that every time we screen a glaucoma suspect or whom we think needs to be investigated for glaucoma, and we refer the patient from the community clinics to the hospital, they do not turn up. So I told him that it is so disappointing that we are not able to translate well to patients that if you do not come in and investigate and do not allow us to start treating you today for glaucoma, you will turn blind in some years and we won't be able to do anything for you then. So I was so disappointed when I was sharing this with him. And I told him, I said, I really don't know whether it is worth even spending our time in the primary eye care clinics, doing an intraocular pressure, doing a direct ophthalmoscopy, and so on. And he told me, Prema, do not give up. He said, today we have patients coming in and asking, what kind of a lens are you going to implant in the eye? He said, that was not our situation 25 years ago. We had to keep telling them what cataract is, what a cataract surgery is all about, what is the success rate of the procedure. And today we have taken so many years where people actually come in asking for a cataract surgery. He said we would probably take 20, 30 years for glaucoma, so we don't give up. We continue doing it, right? The biggest challenge with glaucoma we have is it's an asymptomatic condition. And the only way it could be detected in its early stages is by looking for it. We have to start looking for it if you are not doing yet. And if you're doing it, we are not looking enough. If you're looking for it, we are still not generating enough awareness for people to come, because we still get a lot of patients in our clinic when they come in with advanced glaucomatous damage, and there's little we can do for them, right? So when we look at all the presbyopes who come into our practices, we all get presbyopes in our practices, and almost all of them have the probability of either having glaucoma or diabetes or diabetic retinopathy. The probability is very high, so we need to look for it. Let me share a case with all of you. This is a 44-year-old male patient who comes in for a routine eye examination. The present readers are about 2 years old and are scratched. Systemic history is negative. He has a positive family history for diabetes and no other significant complaints, no other health issues. His previous glasses are both eye single vision readers plus 1 diopter. On examination, his visual acuity is 6.6 in both eyes, and the aided visual acuity is N6 for near. He's able to see with the +1 with a little bit of difficulty. Slit lamp examination was within normal limits. His eye movements were good. Refraction was plano for distance, and with a +125 at N6, he was reading comfortably. He was happy to use his readers, and everything has gone well with this case. What will you do next? Prescribe him his new spectacles and send the patient away, or you would still examine the retina and look for intraocular pressures, right? So on doing his intraocular pressures, we find that the IOP is about 14 and 18 millimeters of mercury. On doing a fundus evaluation, now you could do a direct ophthalmoscopy, but I really don't know in the post-COVID world whether this would really exist as a screening tool. I don't know that, right? Right now, this is an important device which we've been using all these years for screening. Yes, of course, some practices have non-mydriatic fundus cameras. I have a non-mydriatic fundus camera which I use, but I still did a lot of direct ophthalmoscopy pre-COVID. So on examination, the patient's fundus looked like this. The right eye had a cupping of 0.2, and the left eye was like a 4.5 or a 5 cupping. Now this is what we find. What will you do next as a practitioner? Will you order an OCT, visual fields? Will you do a pachymetry? If you don't have it, you can order for these tests today. Will you refer to a glaucoma specialist, or will you refer to a general ophthalmologist? You could choose any of these options. Ideally, referring the patient to a glaucoma specialist could be a stage, because in this case, the pressure was different in both eyes, and he had suspicious looking cupping in the eye which showed the higher of the two pressures. The age also seemed to match. He was 44 years old, and usually that is above the age of 40 is one of the risk factors, right? So this patient is somebody whom you could refer to a glaucoma specialist. If you do not have a glaucoma specialist, you can actually order for these tests, and the files along with this could be sent to a glaucoma specialist if you find more information from these tests. So what is the role of optometrists in referrals? These are some very interesting studies which you can go and read, where in different countries, agreement between ophthalmologists and optometrists on the clinical management and decision making for patients with glaucoma has been done. We do understand for a majority of the early cases in glaucoma or in diabetes, we often just observe the cases. All of them are not treated aggressively. So this clinical management decision making for patients is, we did find studies, several studies actually, where they have shown that there was a very good agreement on what kind of management that needs to be done between optometrists and ophthalmologists. So you could have a good arrangement with your local ophthalmologist to whom you could refer the patient, and then together you can co-manage the patient or monitor the patient. We also have very good Indian studies, because I understand that a large group of the people logging in for the seminars are from India. So I would like to share this Indian study, and if you could read it up, it is by Uday Kumar, where he said that the agreement of glaucoma specialists and experienced optometrists on doing gonioscopy and optic disc evaluation, they found 90 to 95% sensitivity and specificity between both these groups, which means optometrists are equally good in doing glaucoma diagnostics. And several such studies have been reported in different countries. If you are in a country where you are not permitted to do some of these tests, you can always use the non-invasive glaucoma score, which is just a score sheet, and still identify your glaucoma suspects. This is a validated glaucoma risk factor score, which can be used by primary eye care practitioners. Here, all you need to do is to give weightage in terms of age, race of the patient, if they have a positive family history, and when they had the last eye examination. If the score is 4 or greater, then this is a high risk glaucoma case. If the score is 3, it's moderate, and anything from 0 to 2 is a low risk, right? Let's look at another case. This is a 38-year-old male patient who is a banker by profession and who reports with a chief complaint of dryness and discomfort at the end of the day. He had a negative systemic history, but had a positive family history of diabetes and hypertension. On examination, all you observe is the patient was obese. Visual acuity was 6.6 N6 in both eyes. Refraction was plano. Everything was normal. All he showed was decreased tear prism heights, and he had a reduced non-invasive tear breakup time, and the diagnosis was dry eyes and computer vision syndrome. I would like to pause over here and ask some questions. I would like to go back to the audience and ask, what would you do in this case if you are in a country where you would be permitted to use, say you're permitted to prescribe lubricants? What would you do in this case? I would like to hear from some of you. Anybody who wants to volunteer? Practitioners, even students? What would you like to do in this case?
Maybe you all can put it up on the chat.
On the chat
and
box,
we can
yes.
take, yeah.
I've got one response which says more tear function tests. Yes, if you have an access to ameibography, if you can do OSDI scores for this patient, you could do all of that. Yes. But what would you do next in this case? You have diagnosed this patient to have, would you do a DR screening? There's no family, he has a positive family history, yes. All right, you examine the fundus, and the fundus is within normal limits. Here's my answer. So we've done a DR screening and his retina is normal. We've said his vision was 6/6 and 6, anterior segment otherwise normal. What would you do next? But yes, DR screening is a good answer. You would do an OCT. Why would you want to do an OCT for this patient? What are you looking for? Okay, here's what I would do for this patient, and which is what I did.
One more comment there, which says, since he's a banker and because he has more of close work, low
Okay.
readers probably help him.
A low reader would probably help him. Okay, all right.
And then full fundus examination or full fundus view is one of the comments.
Yeah, his fundus was normal, as I said.
Yes.
Because we did do a fundus evaluation for him. His fundus was normal, his pressures were normal. All right, so good. What would you do here? I thought ideally you would end up doing either giving him lubricants, giving him blinking exercise, giving him rule 20-20-20, right? So you would manage the computer vision syndrome. But what I did was I went a step ahead and ordered a complete blood count, an HbA1c, his lipid profile. So I asked for a blood workup because everything was normal, but what disturbed me were two things: his obesity and his positive family history, right? And we received the reports 2 days later. I had specifically told him that once his reports come, he could share a soft copy with me, because today very easily most labs send you a soft copy of the report. So I told him he could send the soft copy of the report to me and also take it to his general physician. And there is what we got. His HbA1c levels were 11.1%. So he was highly diabetic at the age of 38. His triglycerides were high. He had a very poor HDL LDL ratio, and so on. Okay, so what I want you to understand, frankly speaking, I was personally expecting him to be pre-diabetic, but he actually turned to be terribly diabetic with 11.1% of HbA1c values. So one of the markers which have been most documented for diabetes is a large hip to waist ratio, high body fat mass, high BMI, and so on. And he also had a positive family history. Again, if you go to something which is called the diabetic risk score, obesity, age above 30, positive family history have all been given weightage, and you would get a very high diabetic risk score if you ran it on this case. So it's also true that Asians have a predisposition to develop diabetes, and almost 1 out of 3 diabetics in the world live in Asian countries. So this is what we as optometrists should keep in mind, is you do not restrict yourself to only looking at the eye, but you're a primary healthcare practitioner and you need to look at the patient as overall. I do not want to tell you to what diabetic retinopathy is, what are the grading scales. I'm sure you've done all of it. If it's background, you observe the patient. If it is proliferative, you refer the patient. If it is diabetic macular edema, it's an emergency, you immediately refer the patient to a vitreoretinologist, and so on. But the question is, do you want to wait for the retinopathy, or can you prevent it? Your first level of prevention is to prevent diabetes itself. The second level would be is to generate enough awareness to control diabetes or the state of glycemia. If you look at the key figures from the recent International Diabetic Federation Atlas, which was released in 2019, it said that 1 in 2 adults with diabetes are undiagnosed, which is almost 232 million. It also says that there are over 460 million people with diabetes, and the number is expected to grow to 700 million by 2050. That's a huge number to deal with. And 1 in 5 people with diabetes are above the age of 65. Going back to that slide I told you on age, we are soon going to have a large aging population, and 1 out of 5 of them are going to be diabetic. We really need to up the game when it comes to diabetes. I don't know how many of you have heard of this condition called pre-diabetes, right? So here the HbA1c levels are not the normal values less than 5.7, not the abnormal values over 6.4, but in a state of impaired fasting glucose where values are between 5.7 and 6.4. Again, we have Indian studies which said that 14.9% of the people have pre-diabetes, and if no intervention is done within 3 years, 58% of them are likely to convert to diabetes. It is so simple to manage pre-diabetes. Nobody would talk about pre-diabetes in the pharmaceutical world because every diabetic patient is money for them. They calculate their market size based on diabetes. Every patient, if he turns diabetic at the age of 40 and continues to be a diabetic till the age of 80 for the next 40 years, what is the kind of money will this patient spend on managing his diabetes? That's the kind of money which pharmaceutical companies calculate. Nobody is going to talk about because prediabetes is a condition that could be simply managed with lifestyle correction. The first treatment or management of prediabetes is to get the patient to reduce the weight by 20, to bring it down by 20 pounds is what is usually recommended. That is the American Diabetic Association guideline. So the patient has to lose weight, and that itself is enough to bring the blood sugar levels down, and they can continue to be in a controlled state and reverse even the visual function loss that could have occurred. There are several studies that say that a state of hyperglycemia can lead to increased levels of glutathione, which can lead to aging changes, for example, in the crystalline lens. So you would actually see patients in a state of constant hyperglycemia having early presbyopia, having loss of contrast. These are your diabetics with no retinopathy. This is studies reported by them. So you have studies which is reported that diabetics end up having early presbyopia. Diabetics with no retinopathy end up having loss of contrast. Diabetics with no retinopathy also have lens changes and so on. So these are all the signs which are coming in before the retinopathy sets in. So yes, you need to look at the fundus, but if the fundus is normal, do not ignore, because there is enough data to say that neuropathy sets in before all the microvascular changes take place. So we've also reported in one of the ORVO conferences that in patients who were having no retinopathy, early detected diabetics had contrast sensitivity changes. In the visual field, we had a deviation from the MSD values, and also when RNFL thickness was measured using an OCT, yes, you find a reduced nerve fiber layer thickness. So that was a question I was asking on one of the participants who said that you would do OCT. You could do an OCT if you have an access to it and look if the RNFL thickness is lower than normative data. You would find it probably not abnormal, but you would find it a little lower than the normative data reported for that age group. And it would you would also see that in high myopes, right? So, but it is a risk factor, and we should learn to look for these subtle changes before the retinopathy occurs. So look for asymptomatic conditions, ask for investigations, do a complete workup. Legislation stops you in countries from treating. I don't think they would stop you from doing a good eye examination, right? Have a good network of healthcare physicians. It need not just be ophthalmologists, glaucoma specialists. You also need to have good diabetologists, good nutrition, people who give advice on nutrition, and other healthcare professionals. The bottom line is that if you pick up these issues before glaucoma sets in, before diabetes sets in, you can genuinely prevent blindness. So that's my take-home message. You all need to up your game when it comes to prevention of blindness as practitioners. So that's my take-home message. If there are any questions, I'll be very happy to take them.
Okay, thank you, ma'am, for your very detailed and a wonderful talk. I think those who have been your students, they definitely know, like I have been your student, and we definitely know that we have been taught this from the beginning, that optometry definitely is a primary eye health profession, but don't just look at the eye, make sure that the patient's systemic things are not ignored. So I think that's a very important thing to be put up here. There was one comment, ma'am. Somebody said that for the case 2, could we also suggest for a thyroid test?
Yes, I did ask for thyroid tests also in that case. That's why I had put etc. And the
Yes.
thyroid tests were normal. Actually, I only put the list which I found abnormal values on. But yes,
Yeah.
thyroid test was also done, and the tests were within normal limits. Yes, but that is what we need to look for also. It's like now for myopes, most of my myopes in my practice, when they come in, we ask for a D3 test. So, and almost all of them have come with uh, reduced D3 levels, either insufficiency or deficiency with D3. So that's again a very documented thing, that when you have myopic children, you do ask. So you would always be permitted in any country where optometry is not, doesn't permit you to treat, for investigations, right? So you can definitely order blood tests, you can definitely order OCTs, you can definitely order visual fields, and so on.
Okay. Yeah.
What about gestational
Yeah.
diabetes? Gestational diabetes is also a very high number. It is, they say, 1 out of 6 mothers, if I'm not mistaken, are at the risk. And I think 1 out of 3 babies who are having issues when they are born could be because the mother has gestational diabetes. Yes, there are high numbers, but when you suspect gestational diabetes, the patient would also be a female and should be pregnant when you talk about it. But when you have women patients, it's always good to ask if they had a history of gestational diabetes during their pregnancy time. But it's a good question to ask positively. I completely agree with Vivekanand.
Okay. We did have a comment before, I think probably when we were talking about the case 2, somebody also did mention about evaluating more of the of the tear function,
Yes.
and that would help him to ease his discomfort. I think that is also important, but your important take home message is, don't just look at the eye, but make sure that the diabetes level is also being checked.
Yeah, how will we understand HbA1c with pre-diabetic patient? I gave you the cutoff values. It's 5.7 to 6.4. So if you look at the American Diabetic Association guidelines, it says less than 5.7 is considered normal. 5.7 to 6.4 values are pre-diabetic, and 6.4 and above are diabetic values.
Okay.
And if they are known diabetes, 7 and above is considered poor control. Between 5.7 and 7, it is considered moderate control, and anything less than 5.7 is considered good control.
Okay.
SKU, especially in developing countries, how does one manage the testing cost of patient as insurance is very high? Yes, testing costs are high, but most of these tests, basic battery of blood tests don't cost more than 1,500, 1,100, 1,500 rupees. So, well, that is something. And we also have very good point of care tests available, like an HbA1c test. If you do a point of care test, it's as low as 300 or 400 rupees, which could be done in your own practice also. We have these point of care tests available. So those could be used for it. But the regular glucometers, which do random blood sugars or fasting or post-meal blood sugars, are not as sensitive to pick up prediabetes. Of course, random blood sugar also has values. 140 and above is considered to be pre-diabetic. So if the patient not a known diabetic, a random blood sugar of 140 and above is considered as a pre-diabetic value. But the more sensitive test is HbA1c. HbA1c has been American Diabetic Association uses that as a gold standard for diagnosing prediabetes.
There was one question on juvenile diabetes and what are the risks of juvenile diabetes on having diabetic retinopathy?
Very high. Juvenile diabetics do have that risk because they start much younger. It's very hard for the children to, they have much low. See, diabetic retinopathy itself is associated with duration of the condition. So um, we have studies which say that even controlled diabetics, if they are diabetic for 25 years or longer, 70% of them do have retina changes. So with children, since they start at a very young age, we do see at some stage when they are adults or young adults, we do see retinal changes. So it could even be background diabetic retinopathy, but we do see dot and blot hemorrhages. Sometimes we see cotton wool spots. I have seen in a couple of cases like that with it. So yes, with gestational diabetes, I do understand that there is a risk. Uh, how to monitor them is awareness generation is the only way. That's why I said your network of practitioners doesn't stop with just ophthalmologists. You need to have other healthcare professionals. So you need to be always in touch with gynecologists and tell them to talk to their patients on gestational diabetes. And if you think any of them needs an eye exam, to always refer the patients to you so that you could always do a fundus photo or a fundus. So they need to be monitored, and for you to monitor them, then you know where to access them, and the gynae clinics are the places to go. It's just that you need to be really careful before you dilate pregnant mothers and all, because that could be a risk. So you have to be careful that you try to do as non-invasive tests as possible, like non-mydriatic fundus images and so on. Suggest any book or paper to read about systemic. 1 minute. What is that question? I'm not able to read. Systemic relationships. Systemic conditions and the eye. There are several books that would give you systemic conditions. Very basic. You would even get in Kansky. And diabetes, the most recent information is always available online. We today believe more in evidence-based teaching. So if you want to look for recent papers on diabetes and the eye, thyroid diseases and the eye, hypertension and the eye, those are your keywords. Go on to PubMed, look for the recent 5-year studies or 3 years published data, and you would find a lot of information about systemic diseases and the eye. And the eye is truly a window to the rest of the body. Everything from anemia to jaundice, now to vitamin D3s, to vitamin A deficiencies, to diabetes, to blood pressure, to tuberculosis, everything, including COVID, is seen inside the eye. So look at the eye and always think what could be the other systemic disease that could be associated with this condition. Always think on those lines, and you will automatically start looking for them. As I said, you need to look for it. So in case of the banker, near vision difficulty really didn't exist. He just had eye strain and discomfort. Yes, his NPA was, because he was 38, it was not great, but it was good enough for him to have adequate vision. He said he used the computer, his vision was good. He did pretty well with lubricants, incidentally, but I was more disturbed with his diabetes than anything else, because diabetes is known to cause dry eye. It is one of the conditions that causes dry eye, systemic conditions that results in dry eye. So I guess managing his diabetes and with lubricants and with good blinking, with management of his computer vision syndrome, getting him to relax his eye, and all of that actually did well from the eye part, but we also managed his problem systemically. COVID can also affect, yeah, we've been seeing recent papers which says pink eyes, conjunctivitis, viral conjunctivitis is also one of the symptoms or signs of COVID because it can affect mucous membranes. And yes, we do see it in the eye too.
Yep, I think we have answered all the questions, ma'am.
Right?
Yeah, so thank you very much. I think thank you for your wonderful session, ma'am. And I think everybody thoroughly enjoyed. There are a few chat messages thanking you for your valuable time and your comments and answering all the questions.
Thank you. It was my pleasure too. Thank you very much.
Yeah.
Thank you.
Thank you very much, ma'am. Yeah. So we do have a session tomorrow. Tomorrow's session will be more on contact lenses, and Ms. Anjali will be talking to us about the clinical use of a topographer in fitting contact lenses. So please tune in tomorrow. The timings are 2:30 in the afternoon Indian time and 5 p.m. evening in the Malaysian time. Until then, stay home, stay safe, and have a good time. See you tomorrow. Bye-bye.